For years, doctors have been underestimating how painful it can be for some women to undergo certain gynecologic in-office procedures, and now that's finally being called out. So I think that this information and overall concept of undertreating pain can apply to many different types of procedures in the office, including hysteroscopy, colposcopy, especially where biopsies are being taken, and an HSG, to name a few examples. This article came out in response to new guidelines from the American College of Obstetricians and Gynecologists urging clinicians to finally start taking pain more seriously. For the first time, they're recommending that doctors offer real pain management options, not just taking Advil an hour before a procedure, before procedures like IUD insertions and other common in-office gynecologic procedures. This isn't just about saying, okay, you're going to feel a little pinch or a little pressure. Up to 80% of patients, especially those who haven't had children yet, report moderate to severe pain during IUD insertions, and only 9% say that it didn't hurt at all. If you've heard horror stories about people fainting, crying, gripping the table so hard that their knuckles turned white, you're not alone. I mean, this is all over social media. Women everywhere have been talking about their traumatic experiencing pain and not being offered the proper pain management options. So what do the new guidelines say? Well, they are saying that clinicians should be offering options like topical lidocaine sprays or creams, even something called a paracervical block, which is an injection to numb the cervix. And all of these options should be discussed and offered before any in-office procedure that could cause pain. The reality currently is that these are not routinely offered. In fact, only about 5% of insertions involve any form of pain relief or anxiety medication. An HSG is a test, hysterosalpingogram, that I often order to test for whether the tubes are open. And I don't actually perform them myself in the office. I refer these cases to our radiologists. But I do think, given how painful we know this can be for many women, especially when the dye is being pushed into the uterus to push the walls apart, this can cause a lot of cramping. And while it's only momentary, it can be really traumatic and really painful. And I do believe that pain management options should be offered. In fact, there have been many studies on this. There was a randomized controlled trial that actually proved the effectiveness of pain control options before HSG. They actually showed using a combination of high doses of NSAIDs like ibuprofen, Motrin, or extra strength Advil, 550 milligrams beforehand, plus using local lidocaine cream that is applied to the posterior fornix. It's an area behind the cervix and on either side, or combining Advil with a paracervical lidocaine injection or block into the cervix, that these are the most effective ways to reduce pain at time of HSG. And we need to really push everyone to be offering this. I also feel as clinicians that we shouldn't shy away from the option of putting patients to sleep even under light sedation for certain procedures if we know they're going to have a hard time with it or if we know it could be very painful. An example that recently came up in my practice was I needed to dilate someone's cervix. It was really hard to get in. So in order to do that, to be able to successfully perform her saline sonogram, I offered actual anesthesia, and she came into the operating room where we do egg retrievals, and our anesthesiologist administered light sedation through IV medication. And that same patient ended up having her transfer under anesthesia. It's usually not required because a transfer typically is not painful, but in certain clinical scenarios where you know it could be painful or uncomfortable, it does make sense to offer that. I think sometimes these things aren't offered because you're trying to save the patient trouble. You feel like it's a big deal to give anesthesia. And in the case of using topical agents like lidocaine, it's a logistical issue because it can take time and you have to wait a few minutes for that lidocaine to kick in. And also, I think many doctors, when they were trained in residency, they weren't trained to offer and prioritize this step. And it was kind of like this attitude of women just have to kind of grit and bear it. But this isn't just about the physical pain and being able to withstand it. It's about trust, equity, and women feeling like they're being heard. So these new guidelines are really progressive. They're important in emphasizing shared decision-making and giving patients the full range of options, all of the information, offering the choices, and respecting their preferences and their fears and their concerns, especially for those with chronic pelvic pain, a history of trauma, or those who have been historically marginalized in medicine and in society in general. The research is still catching up, and certainly there's a lot more that we need to learn, but the message is clear. Your pain is real, and you deserve options. And if you're planning for an IUD insertion or any in-office GYN procedure, do not be afraid to ask, what are my pain management options? Because you do not just have to tough it out.